So, chapter 47, Cancer of the Testes. Introduction. Testicular cancer are the most common malignant neoplasm affecting men of 15 to 35 years. Approximately 90% of the testicular cancer are germ cell tumors, and it can be broadly classified as seminoma and non-seminomatous germ cell tumor. Male extragonadal germ cell tumor are also discussed. Analogous germ cell sex cord stromal tumor in women, they are not included here. So, incidence in the United States in 2021, the estimated incidence of testicular cancer was 9,470 cases with 440 cases of associated deaths. And this cancer-specific survival rate is approximately 95%. That has led to the millions of testicular cancer survival around the world. Incidence varies among geographic area, and it is highest in Scandinavia, Switzerland, and Germany, lowest in Africa and Asia. Testicular germ cell tumor are most common among adolescents and youngs. They can potentially occur in both boys and men at any age. At genetic background, for reasons that have not yet been discovered, incidence of testicular germ cell tumor can increase over the past 30 years in the United States and throughout the Europe. Although there has been an unexpected increase in the incidence in higher median income countries, mortality rate has stabilized or improved with the refinement of their therapy. This improvement in outcome of patients with germ cell tumors in Western countries contrasts with countries with lower median incomes, where the mortality rate have remained elevated. Risk factors: if we see men whose family history includes first degree related with the testicular germ cell tumors, or who have a personal history of cryptorchidism, they are at increased risk of developing germ cell tumors. Testicular cancer survivors are also at increased risk of second primary cancer in the contralateral testes, and this risk factor suggests a genetic or developmental etiology for testicular germ cell tumor. Although no definitive postnatal environmental risk factor have yet been identified, a study from Sweden found a correlation between heavy cannabis use and the risk of developing testicular cancer. In United States, testicular cancer is rare among African American and most common among white men. And this racial disparity in testicular cancer is diagnosis and its geographic distribution is a genetic linkage, white phenotype, but no high penetrance allele has yet been identified. Testicular germ cell tumor are commonly accompanied by intratubular germ cell neoplasm (ITGCN), which was reclassified by the WHO as germ cell neoplasm in situ (GCNIS) in post-pubertal men, and it is thought that all adult germ cell tumor, with the exception of spermatocytic tumors previously referred to as spermatocytic seminoma, arise from GCNIS, germ cell neoplasm in situ. And the widely accepted theory of the GCNIS begins in utero, and the multimodal GCNIS suggests a field effect within the testes and provides a mechanistic explanation for cases of bilateral testicular cancer. Men without a history of testicular cancer are occasionally found to have GCNIs on testicular biopsy or orchidectomy that was performed for other reasons. The incidental finding of testicular microlithiasis on ultrasound may also provide an evidence of the GCNIs in otherwise healthy men. And the risk of testicular cancer in such individuals has not been determined. The risk of testicular cancer in such individual has not been determined, but they should be counseled regarding a potential risk, increased risk, and to report any new testicular symptoms. And in men with unilateral germ cell tumors who are found to have a contralateral GCNIS, the 5-year risk of development of the germ cell tumor in the contralateral testis has been found to increase to up to 50%. Now, what are the symptoms and signs? Testicular swelling is the most common presenting complaint in most cases, and this symptom is discovered by the patient himself. Patients may also report a pressure-like sensation, heaviness, and mild to moderate testicular pain. This is sometimes confused with the orchitis epidermidis and treated initially with antibiotic. An acute severe pain rarely caused by testicular cancer suggests a different cause of testicular torsion, such as testicular torsion, and the ultrasound examination should be obtained as soon as neoplasm is suspected. One or more hypoechoic lesions seen within the testis Ultrasound distinguishes solid from cystic mass and intratesticular from the intrascrotal extra-testicular location. A solid, so it will distinguish hypoechoic lesions seen within the testis. Ultrasound, which are the advantage of ultrasound, so it differentiates solid from cystic, also intratesticular from extra-testicular location. And a solid intratesticular mass on ultrasound is performed to be a neoplasm. If there is a solid mass intratesticular, then it is presumed to be a neoplasm and an indication for radical inguinal orchidectomy. Approximately 75% of these patients present with testicular mass and no clinical evidence of the metastasis. Other present with the metastatic disease, like 25% present with the metastatic disease, which may also be symptomatic, and primary tumor can be small, asymptomatic even in the presence of metastatic disease. Occasionally they burn out. Burnout means leaving only a fibrotic scar, that is known as burnout primary. So there is no primary, but there are metastasis. Metastasis can be a source of clinical symptoms presentation, such as patient may present with a backache or shortness of breath, cough, or there may be gynecomastia and hemoptysis, weight loss. So in case of burnout primary, that is the primary is very small or patient is asymptomatic about it, or occasionally they may be burned out, such as it is only a fibrotic scar, but there are patients present with the symptoms because of the metastasis like backache, shortness of breath, cough, hemoptysis, weight loss, gynecomastia. Ultrasound of the testis is helpful in establishing the diagnosis even if there is no palpable testicular mass. The detection of elevated serum tumor markers can also be helpful when an occult testicular primary or extragonadal germ cell tumor is suspected. How we will diagnose? The radical inguinal orchidectomy is the standard diagnostic and therapeutic procedure for a solid intratesticular mass. Transcrotal orchidectomy biopsy is specifically contraindicated because of the risk of tumor seeding in the inguinal, and pelvic drainage. So biopsy is also a limited value because testicular germ cell tumor are heterogeneous. Removal of the entire organ is necessary to properly identify histological type. Why biopsy is not useful? Because it has a limited value because of the testicular germ cell tumor, they are heterogeneous. So removal of the entire organ is necessary to identify proper histological type, and to select appropriate therapy. It is reasonable to perform the needle biopsy of the metastatic site in cases of occult testicular primary, burnt out primary, extragonadal germ cell tumor. If there is burnt out primary, then it is reasonable to perform needle biopsy of the metastatic site. That is reasonable. Although the results of the needle biopsy must always be interpreted with caution because sampling error, and the pattern of tumor markers elevation is also informative. Serum tumor marker, that is also informative about the likely cell cycle, cell type present, like seminoma or non-seminoma. Now we will see seminoma. So there are male germ cell tumor, they are broadly classified as seminoma or non-seminoma. It is germ cell tumor. So this is the table. So these are the WHO classification of the So germ cell tumors are intratubular germ cell neoplasm, ITGCN, that is unclassified. Other types, then tumors of one histological type, that is pure forms like seminoma with syncytial or trophoblastic cell, spermatocytic seminoma with sarcoma, embryonal carcinoma, yolk sac tumor, trophoblastic tumor, choriocarcinoma, trophoblastic neoplasm other than choriocarcinoma, teratoma, dermoid cyst, monodermal teratoma with some somatic type malignancies, tumor of more than one histological type, mixed forms like mixed embryonal carcinoma teratoma, mixed teratoma seminoma, choriocarcinoma teratoma, and others.